So first up, we are thrilled over the moon to be joined by Dr. Manali Patel from Stanford and the VA at Palo Alto, and her colleague and community health worker, Gerardo Villicana from Pacific Cancer Care, who are going to talk about the program they have been working together on now for more than 10 years. Manali came on my radar a few years back after she and her team published a paper on this program in JAMA Oncology. They published another one this spring, and the results are really impressive. So we are thrilled at the chance to learn a little more, look under the hood, and here they are to join us. Welcome, Jerry and Manali. Hi.
Hi, thank you so much. It's so nice to be here with friends. And then also I'm really excited to hear and to follow on with the discussion that we just heard, because I think it dovetails very nicely into the work that we've been doing.
So Manali, why don't I start with you? Can you tell us a little bit more about this program and how it started?
So it was over 10 years ago. My mom was diagnosed with cancer back when I was a resident, and I wasn't quite excited about joining oncology just because of the many issues that we saw with many patients coming into our hospital system without advanced care planning conversations, and then quickly transitioning from an inpatient setting to hospice, when perhaps these conversations could have been embraced and engaged upon much earlier in the disease continuum. So I took several years off of my residency and fellowship, clinical fellowship, and launched into a program trying to understand how to use design thinking as well as community-based participatory research methods to better improve care delivery. And what we launched was essentially many evaluations, interviews with stakeholders, including patients, payer organizations, clinicians, as to why these conversations weren't happening or why they were happening too late. And what we heard from patients was that perhaps these conversations could better be engaged upon and with other people like them. And I resonated with that because my mother also found great solace in discussing issues regarding her prognosis with people that were in the waiting room for their screening mammograms rather than their clinician and her own clinician. And so we launched this program without much evidence, had a lot of pushback, both from payers and clinicians about engaging in this approach, but did find a very forward-thinking health systems, including the VA, which is where the first paper that you described was launched, with an integrated healthcare system that paid for a community health worker to be embedded in care. We also launched a program with CareMore where there were reimbursements built in. This was long before the oncology care model. And so there were reimbursements not only for the community health worker, but also for the time that was necessary for the clinicians to engage in such work. And that led to, again, this long standing relationship with community health workers and community organizations to delve into this project.
Wow, so that is a long story, champions, payment models, like all the works that anything needs to kind of go. And that gives us the wonderful opportunity to have people like Jerry be able to do this work. So Jerry, can you tell us a little bit about like what you do, like what's special about the role that you play for the patients that you work with?
Yeah, thank you again for having me here and be part of this amazing panel. One thing that we're focusing on Pacific Cancer Care is discussing about the education. We believe it's really important for the patients to understand their diagnosis as well as the treatment options that they're receiving. We also focus on precision medicine, which is a term that not many patients are familiar with. A lot of our patients think that they're only receiving chemotherapy when they're receiving other options such as immunotherapy, targeted therapy. So we focus on explaining all of those options and how it affects them. But a big focus of our work with our patients is talking about goals of care. This is a conversation that is very crucial to have with the patients, but unfortunately, because of the time strain, providers are not able to have this conversation with the patients. We really care about what really matters most to them, so we can really show that we care for them. And then that really leads us to have a conversation about advanced care planning, helping them fill out an advanced directive, which is something that patients have never heard of in the past. And if they haven't had the desire to fill one out because they're like, okay, I'm doing good, like I don't need to fill one out. So it's definitely something that patients have not wanted to fill out at the beginning. But after having these conversations, the explaining their condition and the importance of filling one out early on has really given them the confidence and the understanding to and the desire to feel one out.
Yeah, I know what when we were sort of talking before in preparation, it seemed like a lot of the things you also do are really addressing non-medical needs in connection with this work, and that's really thinking about their broader quality of life. I guess like Manali, we'll start with you, as your published research speaks a lot to this connection and impact on the cultures, and like what is about the sort of the non-medical needs.
Yeah, I mean, I actually think of serious illness conversations to be non-medical, and somehow in our medical world, these have become medicalized conversations that are supposed to be held, and they should be held between physicians and clinician and patients, but they really need to be started much earlier and can actually be non-medicalized and held even perhaps better with Jerry and other community health workers that are doing this work. There's also this aspect of essentially utilizing individuals who are trusted, that have the engendered trust. Most of our institutions, I know, close your ears, but we have not engendered trust with many of our patient populations. And a lot of my work really focuses on health equity. So I was loving what I was hearing earlier about the integration of health equity. The work that Jerry focuses on, especially in Monterey County, is helping to bridge that gap between an institution that may not have necessarily engendered trust, but being a trusted individual from the community who speaks the same language, who is from and has perhaps even lived experiences as community members, to begin to build these relationships over time such that patients feel more trusted, more open to being able to engage in these conversations. And there's this lack of hierarchy. What we see also with certain patient populations, especially in the VA, what we found is that there's this yes, sir mentality of, whatever you say, doc, I'll do. And oncologists, not to rag on my colleagues, but we are very tunnel visioned often, and we'll think about cancer treatment as we want to treat this cancer, the cancer is growing, the cancer is shrinking, but not thinking the holistic picture of our veterans perhaps not having homes, perhaps the difficult transportation issues that they have to engage in, and then also do our treatments even match with what their goals may be if they have a better understanding of their prognosis and perhaps what the side effects may be of the treatments that they're undergoing. So, a lot of what we do is considered non-medical, but it's extremely crucial because we've medicalized these conditions such that we are so narrowly focused on just treating cancer and serious illness, but not thinking about the person that has the serious illness and the person that's undergoing this diagnosis and treatment.
Yeah, no, I mean, I think that resonates on sort of a lot of scales. Like we heard it over and over again from our research, which is like they just want someone to be thinking about the sort of trade-offs and challenges holistically, as opposed to whatever particular slice of their physiology the clinician is looking at right now. Jerry, when you're talking to your clients about their non-medical needs and sort of supporting this, like how do you see that impact their health and their quality of life and the kind of conversations that you're able to have with them because of it?
That's a really good question. One thing that one of the non-medical needs that we address is just explaining to them that we're a point of contact for them. It can be intimidating to not know who to contact whenever they're experiencing some side effects from the treatment that they're receiving, or any questions about upcoming scans, who they need to call, who they need to contact. And this is where we come in to like close the gap. Even within our practice, where we have a lab, we have an infusion center, they don't know who to direct those questions. So feeling comfortable to contact us, and then addressing those concerns, just addressing transportation issues, financial assistance, connecting them to other providers, the specialists, helping arrange for some of those appointments. Just being there for them has really proved for them to feel more comfortable coming to their appointments, being more active on their care, asking questions during their office visits. Like Dr. Manali Patel mentioned, patients don't feel comfortable like coming to their appointment and addressing these issues. This is when they don't follow up instructions because they just feel intimidated by the presence of the doctor and not being able to explain that, well, they didn't understand the directions of the medications that they need to take at home. So this is where we come in and I really help explain to the patients what's going on. and definitely addressing advanced care planning early on during their treatment has proven to be really helpful, especially having a conversation about hospice, what it means, and helping them go through that process as well.
Yeah,
I think one thing, one thing that
no,
Jerry failed to mention is that he uncovered that many of our patients had food insecurity. And in interviews that we conducted, patients would say, I can't even begin to think about a serious illness conversation or a conversation about my goals of care when I need to figure out how to get food on the table for my family. And so if there was some thought of even a 2-month survival improvement with a particular drug, there may be a decision to continue with that drug rather than perhaps choosing more palliative or conservative measures due to these other aspects that are significantly important complications from social determinants of health.
Yeah, I mean, again, it makes sense. I was at a panel recently, and someone was like, "How do we get more people to do advanced directives?" And I'm like, I think people are making really good, informed decisions a lot of the time about what is most important to them. And so you have to address those things first in order to A, establish trust, and B, because showing up authentically as opposed to doing something that they don't think they need more than other things is one of those moments of disconnection and distrust that impedes us able to kind of have the conversations ongoing. So now, but these are hard conversations. I want to talk a little bit about sustainability in a couple ways. Jerry, first to you, at a personal level, like how do you sustain yourself in this work and protect against burnout?
One of the things that I'm very grateful is as part of this team, we received a visit from a local chaplain. Well, actually, it's a chaplain at a local hospital. We have this conversation with him. He comes into our practice, and then we discuss ways of how to manage the stress and difficult conversations with our patients. So it's a open, safe space for us to really ventilate how we're feeling, and that really helps to remind ourselves of the work that we're doing. Another way is just have an amazing support team. All my teammates are amazing people. Manali is really helpful in having these conversations with us, as well as the other community health workers at the practice, and just reminding ourselves that like the small acts that we have with our patients can go a long way with them. Simple call to checking how they're doing after their treatment goes a long way in them feeling comfortable approaching us and seeing that we really care about their well-being.
Yeah, that makes a lot of sense. Good teams make a difference. So Manali, obviously thinking about sustainability a little differently, how do you fund this? How do you ensure a sustainability so that we can all have a Jerry? I want a Jerry.
I do too. We're so lucky to have Jerry. I think it's always been a point of interest of mine is how to sustain these models. I hate that, we come in with our grant funding, often from institutions, we don't think about the sustainability, the funding ends, and there goes the community health worker models. And so one piece that I've really been focused on is ensuring that we have the right stakeholders at the table. So we always have a community advisory board. Even in the VA study, we had a veteran and family advisory board where we also have executives from the health system and the county that are included, as well as policymakers, in terms of if the model shows effect and there's a benefit, your goal, right? Our goal is that this will continue to sustain and that there's a commitment that is made by these stakeholders to continue the model. So we did the same approach down in Monterey County, which is where Jerry is working, where we had policymakers. And as Jerry mentioned, this actually was a study that was focused on precision medicine. So we had precision medicine funding that then integrates community health workers into engaging patients with precision medicine care. But what it's done now is demonstrated the implications of community health worker models such that policy changes can be made and there's reimbursement that is embedded now through Medi-Cal, where patients can actually and providers can bill for these services. It's still not enough, so it's $12, but it's better than zero. And what it has also done by having stakeholders at the table before we launch these programs is it also, even without the reimbursement, the clinical lead, for example, that's working with us and our community partner clinical lead had already embraced this model after the great benefit that Jerry showed, which, we haven't completed the study yet, and we haven't completed, at least for the precision medicine piece, the outcome piece. But we do 100% know that it has made such an impact that the clinical lead said, oh, Jerry's with us, right? We've got this community health worker model that's going to sustain. What I worry about is the community health workers. And so as Jerry mentioned, we built in, after doing a small evaluation of the community health workers in prior studies, we found the concern for death and dying and grief, which we all experience and I experience on a daily basis, to be quite dramatic amongst community health workers who have a unique relationship with patients. And so we built in chaplain and palliative care services to also help with burnout and concerns about grief and dying. But I also worry about retention of community health workers. This is considered mostly a transitory role where Jerry's probably going to go off to medical school and so going to leave a void for us. So how do we continue to retain community health workers and then also advance their careers, but have a pipeline of individuals that may want to go through this process of becoming a community health worker, moving on, but then there's also a unique opportunity for other individuals in the community to take on these roles. So we've had lots of turnover in our programs just across the United States. So I think about addressing turnover. For Jerry, how to provide ongoing mentorship for career advancement. The fact that he was invited for this panel really warms my heart. And also, he's too humble to say, but he's about to be awarded at the AONN conference now for being an amazing community health worker who also fills a role for navigation. Among the many other things that he does. But how can I and the teams provide ongoing mentorship and support, especially when they are more sustainable models in the community? And also, how do you support patients as there are turnovers, right? Where there's vacation or time off. We want community health workers to not only be compensated for their role equitably, but also to have PTO and time off. And so that means that there would need to be more Jerrys in the clinic than just one person, and that there's some level of team-based management such that there are a covering for any sort of gaps that may arise when a community health worker may be out.
Yeah, I want to pick up on a couple of things you both have mentioned but I keep on thinking about training. And I'm thinking about training in a couple of different ways. It's sort of like, what are these critical skill sets? And I think about it in two ways also, because you guys were, I think, listening in at the beginning, is that part of the gamble that we're making right now is that if we lean into things that aren't just for people with serious illness, because it's so challenging to catch people at the right time, and because the longitudinal nature of relationships, the longitudinal nature of complex chronic diseases. So it's like, when we're thinking about, I'm going to ask a two-part question. One is like, when we're thinking about these skill sets, what is a skill set that's important for people as they be, sort of like have illnesses that become serious and advanced? Like, is it really any different than any sort of like any, kind of more standard or sort of like general practice community health worker? Are there specific skill sets, or is it really just like the core of a community health worker, which is connecting with the person, connecting a person to the things they need? Like, how do you think about those buckets of skills? I'm going to talk with Jerry first, and then Manali, you can chime in after.
I feel like you touched on a really good point. I feel like in terms of training, there's certain basic skills that like a patient navigator or a community health worker should possess in terms of like really finding out what resources are out there in the community available for the patients, but also within the clinic. Like once again, connecting those gaps, connecting within all different departments within the facility. But also, I feel like it should be tailored for each individual facility, each individual specialty. Where, like, for example, for a primary care practice, they might focus more on like screening and prevention. Whereas here for an oncology practice, it's more about teaching patients about their treatment, starting with the basics of what cancer is, because just hearing the word cancer means they might think, okay, this is the end. But no, there's still like with the advancement of research, clinical trials is showing the importance and in the education of the patient. But definitely the basic training on patient navigation, motivational talks with our patients, and it's something fundamental in the training of community health work.
Yeah. Manali, what do you think about, you think those sort of balance between the sort of generalist nature and the specialist nature? Because a lot of people are interested in community health workers for serious illness, but I would hope that we don't create more silos than we need, because one of the beautiful things about community health workers is that the way that they can traverse silos.
Yeah, so I think it's interesting because we hire for Jerry's. So it's, people say, well, do they need a particular background? Who do they need to be? There's really this service orientation that comes across when you meet people in an interview. And so, and it's kind of intangible in terms of who to hire. So there is really this natural fit for who would be right at having these conversations. And I actually think the training is more to help community health workers feel more comfortable. But I think the conversations are really just conversations, and there isn't much training. In fact, Jerry's not going to tell you, we kind of threw him into the mix. We trained him on navigation, and we did all these motivational interviewing things, and we sprinkled in some palliative care, and now we're actually really launching this PCORI funded trial where his main focus will be just on advanced care planning and also symptom assessment. So delivery of palliative care, which is usually traditionally reserved for palliative care physicians and also clinicians. Where he's received more training, but I actually don't think Jerry and other community health workers that are fit for this role need that advanced level of training. They are hired to essentially connect with patients, and those conversations, even though Jerry was mostly focused on precision medicine, he would describe cases in our case conferences that he had essentially navigated people into palliative care and to hospice, and had addressed hospice conversations without having much training in that area. I do think training does help. Again, having words that work, resources, and also I think what's incredibly important, as I alluded to before, is that mentorship piece of case conferences, being able to describe issues that come up, how to address particular concerns, how to engage patients regarding advanced care planning. That's critical, but it's not your routine training pieces. And again, it's an interesting question. We have training curricula that we've created and we use, but I actually think it's more to make the community health workers feel more comfortable rather than them actually needing to have that training to conduct the work that they do.
No, and that makes really sense. And I want to pick up on the other thing that both of you sort of mentioned with some of these trials focused on precision medicine. That's clearly not advanced illness, serious illness, end of life. And we were talking a little bit before we started, a cone of transparency to the audience. I think one of the things that I didn't realize when I was looking at those papers is that those models, even though you reported on the advanced cancer patients or the people who are within the last years of life, you don't in any way limit this to people with serious illness. Tell me why. And maybe do you think that's one of the reasons why you're getting such results? Because you're not putting some of those barriers to enrollment in place.
Jerry, do you want me to take this? And I'll have your thoughts about what you do in the clinic as well. I have always been of the mindset that these conversations should be like when we sign up for a driver's license and we're asked, do you want to be an organ donor? Well, we don't think twice about it, right? And we say yes, no, and then we get our driver's license. And so why these conversations have been so attached, they're important, and they need to be had when you're making any sort of treatment decision, regardless of stage of disease or type of disease. I like to know what my options are and how to engage with my clinicians about my prognosis, even if I don't have a serious illness, but I may have hypertension and want to know the treatments and the side effects and what the likelihood would be of additional clinical visits on my life to be able to make decisions about whether I would want to undergo a treatment that's by pill for hypertension or come in every week for a blood pressure visit. Something as simple as blood pressure management also requires people to make decisions, and especially for patient populations who may be from communities where working is really important and employment and dual employment is important and it requires time out of their day. Our clinics are open mostly during business hours. And so it is inconvenient for someone to have to come in for a clinic visit and may make their decision may alter their decision depending on what is required for them. Having that anticipatory guidance, I think, is really important. And yes, like you mentioned, we never limited it. We heard from clinicians because, again, we like to cater to our stakeholders. So a lot of oncologists were really worried about these conversations being held too early with patients. And so we got a lot of pushback. Again, this was 10 years ago, but pushback from oncologists, and even still now when we've been launching the PORI study, about whether these conversations need to be whether we need to wait until patients are at a critical time juncture for having these conversations. But it is a paradigm shift, and it requires us, again, demedicalizing these conversations and thinking about them as necessary to have early. And then as patients begin to develop the activation, you see this enduring effect. And even in the VA study, right, we've got patients that lived 15 months later. And what you saw was that the intervention was 6 months up front, no contact with patients after 6 months, and the enduring effect lasted. So we were hoping that perhaps even if they don't pass away from cancer, they may pass away from heart failure, and they need these skills to engage in that illness conversation. So again, thinking about it holistically from the patient's view of what skills do we need to embed for a patient to be activated in healthcare in general as it relates to serious illness. You know, that same skill set would be important as they are nearing the end of life. Jerry, I'm going to turn this over to you because I would love to hear your thoughts about this.
No, yeah, I absolutely agree with Manali in terms of the importance of having this conversation with our patients early on. Ideally, we would like to be having these conversations as soon as a patient is referred to our office, as soon as they're diagnosed with cancer. Just because they're at this stage in of their lives, they just find out about this. They're making a lot of decisions on their personal life, having all these conversations with family members, and just trying to understand what's going on. And we believe that at that moment, that's when they really need to have these conversations. But also, it's when they're still like stable, their health condition is still stable before they start treatment, before they start experiencing all these side effects. So we want for them to make the best decision. So that's the way I try to explain it to them, the importance of having this conversation early on. And because a lot of times we just don't want to think about it. And when we discuss this with our families, it's right when we're already on bed. And unfortunately, that may be a little too late for that. And that's why, like, I start discussing the goals of care. What is it that matters most to them? And then after discussing everything that's going on, that's when I have this conversation. For example, really quick, I want to share a case with one of my patients who was very hesitant about talking about hospice. Like they say, like, no, I've heard from family, from friends, neighbors. Hospice is when, like, that's it, like that's my end. But no, like really talking about different hospice options. So we went through. I helped them fill out an advance directive. He brought it into our office. He shared with a local hospital as well as with some other providers. Sadly, his condition progressed, and he actually ended up going to hospice. A patient who was very resistant to the idea of hospice, we discussed, and he actually receiving hospice services at home because he knew that, like, he didn't want to be at a facility. He pictured it like from movies, like this ugly place where family members didn't even want to go. But he received a lot of attention, a lot of care. Nurses coming to their house. Family members were very grateful. They would still call me and tell me how grateful they were for our support, for our continuous communication. So even though he was already in hospice, we were making sure that they were receiving the services that they needed. And the patient actually passed away very peacefully at home, surrounded by his family members and with the attention that he deserved and wanted from our previous conversations. Yes.
Yeah, I mean, when you start early enough, you have so many opportunities to be able to kind of build relationships and kind of support people in their prognostic understanding. I think prognostic awareness is a really technical term, but we say it a lot, like people can't engage in shared decision-making if they don't actually know what the trajectory of their sort of illness could look like. I think that is one of the critical things that we need to do a lot better job on. And it's amazing, Jerry, to hear how much time you spend just kind of giving people the basics going through sort of like helping them understand the ways this could play out and what that's actually going to mean for them. So I have a couple of questions from the audience that I wanted to bring back to you. One of them was just like, do you find that you need to like convince people to talk with Jerry, the community health workers, versus their specialists? Do you ever get that pushback being like, oh, I want to talk to my doctor as opposed to the community health workers?
No, I feel like so far I feel like I really portray myself as someone that I'm just there to answer like certain questions, just any inquiries. I always since the beginning I said like I'm just a point of contact. I'll try to answer any concerns that you have. But definitely I understand my scope of service. So if there's a very technical medical questions about like, okay, how many more cycles do I have of treatment, or what medications am I taking, when to stop them, that's when I relay the information to the providers, to the triage nurses, to the correct person. But in terms of having this conversation with patients, they actually seem like someone that they really trust because I've spent so many hours talking to them, both in person, over the phone, or sometimes even over video. They love to chat over video, and just see that someone that who cares and who's there, especially because a lot of our patients that we're helping are Spanish speaking. So I'm there during their office visits, there with the providers, and just the role that the providers take in terms of like introducing me for the first time. They gain the confidence that they can talk to me, and I'll first of all care for them, but also relay the information and get the most accurate information back to them.
Yeah, I think the team-based model works. We've now done this a couple of times where we've had kind of community health workers not embedded in teams, just because we've had some difficulty with some oncology providers many years ago with embracing such models and also embracing such conversations so early upstream. And what I've seen is that initially patients in those models may be a little bit more reticent to talk to the community health workers, especially if they may be linked to a payer organization, for example, or where we found great success is also with a labor union organization, which was also the health plan. And so they were already embedded as part of chronic disease management and were trusted resources already. And so we're pretty easily accepting of the model rather than discussing with clinicians. But even where we found in the VA, where there was initially some pushback by veterans of who are you and why are you calling me, and are you with Dr. Patel, or who are you representing? What we found was that over time, because the community health worker was more accessible to handling scheduling issues, like Jerry mentioned, they then became the first point of contact for everything. And in that first paper that we wrote, it was really just focused on advanced care planning, even though we had hoped to do symptom management as well. We got from the clinicians, let's just focus on advanced care planning. We don't want to do any symptom management right now. And the community health worker then became the first point of contact for any symptom. And they would be contacted. And then it just kind of organically developed into this, you've got to address symptoms before you can engage in advanced care planning conversation. And so it just naturally melded into a symptom and advanced care planning intervention where there were triage and workflows that had to be developed. It's a very good question, but actually we found the opposite, that once the community health workers have embedded a relationship with patients, it's hard then to have a meeting actually. And I saw this with my own clinic, that they would ask, where is Laviva, right? Where's the community health worker that was supposed to be here? Why are they not here? And I don't want to talk to you until I have her, present, or my list of questions that we had gone over that she was supposed to remind me about.
All right, we have time for one last question that I have some from the audience. It's just going to be like like playing on this theme again, but it's like, it sounds like you are nuanced and flexible with the way you incorporate people into teams, the way some specialists accept them and some specialists don't. Like the actual question is, how do we change that tunnel vision of specialists to engage them more in this important work? And what I hear you saying is sometimes you can and sometimes you can't. You just do it off the side anyways.
Yep. You do it any way you can get it, because, and so we built in these models, and it will be an interesting study because I always think about what's the most effective way to embed and to approach such models. I do think that there's a lot more there's so many more benefits if it's embedded. What Jerry's able to do is kind of bridge this community with the clinician. And when you embed that approach, then the clinicians can actually introduce Jerry from beginning. And it really serves as this team-based model, which I think is the ideal approach. But if you can't get there, there's so much benefit. And we're just about to publish, we hope, but we presented at ASCO annual meeting, was what you do when you don't have an embedded model. And there are some clinicians that just will never embrace non-clinicians discussing what's considered a topic that should be only reserved for clinicians to discuss. And so what can you do in those situations, and what does the model look like? Looks very similar in terms of activating patients. There's just not that dual bidirectional conversation with the clinical team, but you're helping to hopefully engage and activate patients to become their own advocate in these conversations, which then would serve them if potentially they don't have cancer but have heart failure. So there's benefits for both approaches. And so we just do it as we can, trying to make a difference and trying to improve these models and advanced care planning conversations.
Well, we are out of time. This has been like, clearly we could keep on yammering on about this for like ever and ever, because it's just really exciting, and the different permutations that you have been involved in, like how that sort of works. And I think, Jerry, we've only scratched the surface of the sort of wisdom and insight that you bring to as you're journeying with people through this sort of time in their lives. And so maybe we'll, watch this space, hopefully come back to you and talk about it more, because I just hear so much energy about the potential for community health workers in everywhere, but in Massachusetts and in serious illness specifically. So thank you so much for joining us, and from California and New Orleans, and congratulations, Jerry. Bye, guys.
Thank you so much.
Thank you so much. Thanks, Jerry. Bye.